Good morning, everybody, and welcome to the second in our Maternity Matters bite-sized series. As this is our bite-sized series, it's been devised to focus on a single subject with a single eminent speaker, and today's webinar will focus on jaundice. My name is Sharon Williams. I'm a Senior Associate Solicitor in the Urban Mitchell Manchester office, and I'm joined today by Dr. Simon Mitchell, who is an eminent neonatologist and expert on this subject. I'll properly introduce Simon shortly once I've spoken a little bit about the legal background to these claims. Before that, though, a little bit of housekeeping. So thank you to all of those that have already submitted questions via their registration form. You can, of course, continue to ask questions throughout the webinar using the Q&A function on your screen. And at the end of the presentation, we'll try and get through as many of them as we can within the time. If you could please submit your name and email address with the question, then if we don't get time to answer your question today, we can come back to you on email. We will, of course, be recording this webinar as well, so within the next couple of days, anyone who has registered will receive the link to the recording, and all of our previous Maternity Matters webinars can be found on our YouTube page. Towards the end of the session, we'll post a link to a feedback form. Please do take a few minutes to leave your feedback, as it does help us devise the forthcoming webinars in the series. And now moving on to the legal context. I don't propose to talk too long about this, as I know that Dr. Mitchell has some case studies in his talk which really do highlight how this works in the legal field. But in relation to the legal context, properly identified and treated jaundice ought to have no long-term effects. Unfortunately, at Urban Mitchell, we do see those cases where jaundice hasn't been properly identified or treated, and in the worst cases can lead to permanent brain damage, which is known as kernicterus. Anyone that has seen our webinars before will have heard about the legal test that applies in medical negligence claims. But just to recap, or for people who are joining us for the first time, there is a two-pronged test. First of all, there's breach of duty, known as the Boland test, and that relates to whether the standard of care would be supported by any reasonable practitioner. That standard depends upon relevant professional standards, the type of field or discipline that clinician is working in, as well as local and national guidance. We then have to prove causation, and that is on the balance of probabilities that the negligence or substandard care has caused the injury complained of, or to put it another way, that with reasonably competent care, the injury would have been avoided. In relation to the standards to be applied, they're dependent upon the age or gestation of the baby. And common themes that we see with regards to these cases relate to failures to spot warning signs, so to speak, such as when the associated post-birth weight loss is too high, false reassurance as to serum bilirubin levels, not recognising that repeat tests ought to be performed, a failure to recognise infants at risk, a change in colour of stool, or the change in colour of skin, in particular in black or brown infants, or delays in arranging treatments such as phototherapy. Today, we have Dr. Simon Mitchell, who will talk through the condition of jaundice, the risk factors, kernicterus, and some case studies that he has been involved in. Dr. Mitchell has 23 years experience as a full-time neonatologist and was appointed to the Regional Neonatal Intensive Care Unit at Salford in 1999, before moving to St Mary's Hospital in Manchester in 2003 until his retirement last year. Dr. Mitchell has a doctorate from the University of Dundee for his research in cerebral palsy, and was also honorary professor in the School of Healthcare Professions at the University in Salford from 2009. Dr. Mitchell currently works as an expert witness in medico-legal cases and has assisted us in many cases that we've worked on over the years. And I'll now hand over to Dr. Simon Mitchell for his presentation.
Thank you, Sharon. Thank you for the invitation to ask. Next slide, please. So what I wanted to talk about today in broad terms, just to figure what is jaundice. It's a common condition, but to try to understand what it is and why it happens. Also to understand why newborn babies are at greater risk from jaundice. We need to understand the associated clinical risks and the potential consequences of jaundice in the longer term for the baby as well. Importantly, we want to consider treatment, the options of treatment, and more importantly, prevention of complications arising due to jaundice. And then I'll make a few comments about some specific considerations which are relevant with reference to some specific cases. Next slide, please. So bilirubin itself is the chemical. It's the chemical which gives the yellow appearance when it's deposited in the skin. So jaundice is actually the yellow colour due to higher levels of bilirubin in the subcutaneous tissues because it's in the circulating blood. Bilirubin itself is a breakdown metabolic product from proteins which have got a porphyrin ring in them, which is a protein structure, and the most common protein that has that porphyrin ring is hemoglobin, and other heme-containing proteins, particularly hemoglobin. Bilirubin itself is conjugated in the liver to glucuronic acid. That's a chemical process, and that means it's then excreted in the bile, and that's one of the things which is pigmenting the stool in normal cases. It's common among newborn babies to get what we call physiological jaundice, which is generally benign if it's uncomplicated, and it just reflects the limited capacity to metabolize bilirubin combined with a very high, relatively speaking, bilirubin load in newborn babies. So they've got a lot of it lying around and they've got a limited capacity to excrete it and get rid of it, so it builds up and they become jaundiced. When bilirubin is in the blood, it's generally bound to the protein albumin, which means it's not free to float around. And it's the unbound bilirubin, which is a smaller amount of the total bilirubin, which has the potential to cross the blood-brain barrier into the central nervous system. And if it does do that, then it can be directly toxic to neurons, and by various different factors which involve disruption of energy metabolism in the cell, disruption of cellular membrane transport, and also initiating apoptosis, which is the process of programmed cell death. You can get neuronal loss. Some parts of the brain are more vulnerable to bilirubin injury than others, and the reasons for that are not at the moment completely clear, but it tends to be the deep grey matter, particularly the globus pallidus and the auditory nuclei, which are a particular high risk from bilirubin injury, and these are the parts of the brain which get injured in kernicterus, which is the ultimate bad outcome for severe jaundice and bilirubin encephalopathy. Next slide, please. So turning to bilirubin turnover in the newborn period, remembering that bilirubin is an entirely normal physiological breakdown product. We've all got it in our circulation, we just excrete it. So bilirubin production in a newborn baby will be a lot higher than in adults or in older children. Newborn babies have a larger circulating red cell mass, and they've also got a reduced lifespan for their circulating red cells. So immediately you've got a bigger burden of hemoglobin, which is being broken down and producing bilirubin as a byproduct, which has got to be metabolized and excreted, otherwise it will build up. When I talk about increased enterohepatic circulation of bilirubin, I will show you a picture shortly, which I hope makes that a bit clearer. But essentially, it's a bit like taking 2 steps forward and 1 step back for the liver. The liver is dutifully conjugating bilirubin and excreting it in the bile, but a component of the excreted conjugated bilirubin gets broken up and deconjugated, which means that it then gets reabsorbed and has to go through the same process again. So that's what we mean by enterohepatic circulation. The things which are important in that are the presence of an enzyme called beta-glucuronidase, which is present in breast milk, and also the bowel flora. If you've got certain organisms like lactobacilli, which tend to colonize the bowel when you're breastfeeding, they're good, healthy, probiotic organisms, but they're not very good at converting the conjugated bilirubin to urobilinogen, which is the component which can't be reabsorbed. If you have a baby who has formula feeds, they tend to get their bowel colonized with coliform bacteria, which are the less favorable bacteria, but what they are good at doing is converting bilirubin to urobilinogen, which can't be reabsorbed. So for that reason, breast milk jaundice or breastfeeding tends to potentially physiological jaundice, but that doesn't mean it's harmful. It just explains why some babies who are breastfed may remain jaundiced a little bit longer than others. And finally, the liver itself is immature, so the glucuronidase activity, that's the UDPGT enzyme, that's the enzyme which has the function of conjugating bilirubin with glucuronic acid, so it's excreted in the bile. And if that capacity is limited, then clearly it can only work at maximum speed, and that can lead to an accumulation of bilirubin because you exceed the capacity of the immature liver to be able to conjugate bilirubin. So those are the main mechanisms of what we would refer to as physiological jaundice. Next slide, please. So this is the diagram I promised you. So starting at the top left, we've got our heme containing proteins which get broken down. The iron and the rest of the protein gets scavenged, and one of the breakdown products here is carbon monoxide. And that's useful from a research point of view because it is possible to use measurements of exhaled carbon monoxide to confirm whether there's active hemolysis going on. It's not used in a clinical context, but in a research context, if you want to confirm that there's an increased rate of red cell breakdown, you can detect exhaled carbon monoxide from here, which is a demonstration of increased hemolysis. So the initial product, biliverdin, is converted to bilirubin, and that is transported in the blood, mainly bound to albumin, to the liver. And the liver then conjugates the bilirubin, so with glucuronic acid, and that's excreted in the bile. Once it's in the bile and excreted into the bowel lumen, then some of it gets broken back up by the action of the beta-glucuronidase enzyme, which is predominantly present in breast milk, and therefore gets reabsorbed. So that's what we mean by enterohepatic circulation. Whereas the bacterial action, particularly from coliforms, but other bugs as well, converts the bound bilirubin to urobilinogen, which can't be reabsorbed, and that's one of the pigments which gives the stool its brownish colour, and that's excreted in the feces. So that's how we're generally rid of our bilirubin load, but it's how, particularly in a baby who's either newborn because they've got a limited capacity to conjugate bilirubin, or especially breastfed babies because there's a different bowel flora and there's a bit more beta-glucuronidase enzyme in the milk, they can have a like 2 steps forward, 1 step back effect, enterohepatic circulation of the bilirubin. So that's how breast milk jaundice comes about. That's the basis of physiological jaundice, which in itself is not a harmful thing as long as it's not complicated by other factors. Next slide, please. So, as we said, when you're first born, bilirubin metabolism, the activity of the glucoronide-transferase enzyme is limited. The main conjugator is within that primary exon of the gene, and at fetal levels, you've got very low levels of glucoronide-transferase activity, about 0.1% of adult levels. By the time you get to about 30 weeks, it's about 1%, and a little bit more than that by term. The good thing about bilirubin is that it tends to, it induces its own metabolism. So although the bilirubin conjugating capacity of the liver is very low in an immediately newborn baby, once it's exposed to bilirubin, it induces that enzyme. So the enzyme activity increases. And so by the time you get to about 6 to 14 weeks of age, you've got an adult level, but even by about 7 days of age, you've generally got a much better capacity to conjugate bilirubin, which is why the physiological jaundice is a self-limiting process in most cases. So bilirubin directly induces its own metabolism by stimulating and upregulating the glucoronide-transferase activity in the liver. Next slide, please. So the consequence that we're all concerned about for bilirubin is what we would call bilirubin-associated neurological injury, and I'm going to deliberately stick to the worst end of this. There is a deal of interest in bilirubin-induced neurological dysfunction, BIND, in which there is arguably some longer-term sequelae to exposure to high bilirubin levels, but you don't get full-blown kernicterus. I think these cases are rather less common and a bit more difficult to tie down. So I'll stick to formal kernicterus as it stands at the moment. So if you have a flow of unbound bilirubin across the blood-brain barrier, then it will then get across the cell membranes and into the cytoplasm of vulnerable neurons. The clinical symptoms that we'll see in a baby is bilirubin encephalopathy. They may be subtle, but the first sign will be a degree of hypotonia and lethargy, often associated with poor feeding, disinterest in feeding. Common symptom perhaps, but one to be very much aware of, because at this point the situation is likely to still be retrievable if you can get the bilirubin levels down. The second stage, the baby becomes more irritable, hypertonic, and they get this opistotonic posturing, which is neck extension, arching of their back, and often a high-pitched cry and marked irritability as well. And that's a real danger sign of bilirubin encephalopathy, and it indicates urgent intervention to bring the bilirubin level down. Otherwise, we're going to be in real trouble. The babies of the end stage bilirubin encephalopathy generally become less responsive, very lethargic or comatose, and hypertonic, with continued back arching as well. So those are the evolution in time of the clinical symptoms of bilirubin encephalopathy, and it reflects the fact that the bilirubin is crossing the blood-brain barrier, it's getting into vulnerable neurons, it's causing injury, and the encephalopathy is a symptom of that. It's analogous to hypoxic ischemic encephalopathy, which we see following an asphyxial insult. It's a symptom of the developing brain injury. In the longer term, there's a very heavy burden of disability associated with bilirubin encephalopathy, generally termed kernicterus, although the term kernicterus, strictly speaking, is it's a pathological term, and it describes the yellow coloration of the basal ganglia and those parts of the brain at post-mortem, obviously historically. So that's the literal term kernicterus, but it does tend to get used as well to describe a baby who's got brain injury due to bilirubin toxicity. So the long-term problems are mainly what we call extrapyramidal or dyskinetic features. So this is a reflection of injury to the basal ganglia, and one of their important roles of the basal ganglia as that part of the brain is to control and manage movements. So dyskinetic features would be these sort of continuous writhing athetoid features that you can see in athetoid cerebral palsy, or you can get dystonia, which is often triggered and uncontrolled extension and variability in tone, quite disabling. Typically from the textbook you get a vertical gaze palsy, you lose the ability to look up, so that's an abnormality of eye movements. You may often see staining of the enamel in the teeth, that's also in the textbooks, although usually we've recognised bilirubin toxicity before you get to that point. There's a high prevalence of hearing loss, and in particular the pattern of hearing loss tends to be that of auditory neuropathy spectrum, when you may have preservation of otoacoustic emissions because cochlear function is normal, but you have a loss of auditory brainstem responses because the injury is retrocochlear, it's affecting the central auditory pathways. It's a mixed bag, I suppose, but one of the distressing things about kernicterus is that the cognitive development tends to be relatively intact. So of course it's good if your cognitive development is intact, but you have somebody who's got intact cognitive development with very severe physical disabilities. So it's a very severe and very nasty lifelong disability, which you would never wish to see. Next page, please. So there are some factors we can recognise which will increase the vulnerability to bilirubin-induced brain injury, and these are largely going to be factors which are going to predispose or increase the likelihood of transfer of unbound bilirubin, which can cross cell membranes into the central nervous system and therefore to the vulnerable neurons. So in the blood, if you've got a reduced capacity for albumin binding, remember it's only the unbound bilirubin which can cross into the brain. If you've got reduced albumin binding, you've therefore got more unbound bilirubin. So in broad terms, if you've got low albumin levels, if there's less albumin around, then there's less albumin to do the binding. If you've got reduced albumin binding itself, well, that could be largely, it's to do with hydrogen ion concentration and acidosis at a molecular level, but these can affect the ability of albumin itself to bind bilirubin. So a degree of acidosis can predispose to this by reducing the efficacy of albumin binding. And then displacement of bilirubin from albumin binding sites. This is quite rare now because there's an awareness of it, but there were some drugs in particular which back in the 1950s would have been given and would be preferentially bound by bilirubin, but by albumin, therefore leaving more unbound bilirubin. But that would be something which is really for the history books rather than the textbooks now. Anything which increases cerebral blood flow could in theory increase the transfer of unbound bilirubin to the blood as well, because there's a continuous increased exposure. And one of the things which is recognised that is hypercapnia. So raised carbon dioxide levels tend to give rise to cerebral vasodilatation, and that leads to an increase in cerebral blood flow. We usually are more concerned of hypercapnia for intraventricular hemorrhage, because the germinal matrix hemorrhage is more likely when you get a swing in blood flow, and it tends to be a reperfusion injury, so hypercapnia is a feature there. But it can also be relevant as a predisposing factor for bilirubin-induced brain injury. And finally, factors which disrupt the blood-brain barrier. And the blood-brain barrier isn't like a fence. It's effectively the endothelium of the blood vessels going through and serving the brain. So they're normally quite tight, and anything that makes them leaky will allow increased passage across this endothelial barrier. So acidosis and hypercapnia both have that effect. Asphyxia, through broadly the same mechanisms, will have that effect, but also because it compromises autoregulation of cerebral blood flow directly. And then endothelial inflammation, and that goes generally with infection. Meningitis is a particularly high risk, but systemic infection and a systemic inflammatory response is also a risk factor for disruption of the blood-brain barrier in this way. Next slide, please. So preterm infants have to be considered as a more vulnerable group. And you'll all be aware that when we have our bilirubin threshold graphs, the threshold for commencing phototherapy is lower for preterm babies, and it varies according to gestation. And you can see that from the NICE guidance. I'll show you an example in a minute. And that means that we tolerate a lower serum bilirubin level in a preterm baby, and our threshold for intervention to bring it down is lower in a preterm baby. And there can be a number of reasons for that. Firstly, as we've already indicated, bilirubin metabolism matures later in preterm infants, so they're likely to have a more limited capacity to conjugate bilirubin, so they're more immature. They're also more likely to have experienced additional risk factors, including infection, including a degree of hypoxic ischemic insult or acidosis. And also in a preterm baby, there's a greater potential for coexisting or concomitant neurological injury, and that's really referring to germinal matrix hemorrhage or white matter injury, which would be developing periventricular leukomalacia. But if you've got even very mild or developing parenchymal brain injury, it greatly increases the vulnerability to bilirubin-induced brain injury as well, to the point that that can become the predominant injury. So preterm babies are at a greater risk, and that's broadly the reason why we set a lower threshold, so that they're not exposed to such a high level of bilirubin, because they're more vulnerable to it. Next slide, please. So in terms of treatment for jaundice, this broadly isn't rocket science, but the two things that we want to try to take measures which will avoid potentially damaging serum bilirubin levels. So you don't go from nothing to a dangerous level without passing through other levels on the way up. So it's anticipating that. And so phototherapy, blue light phototherapy, is the mainstay of our treatment. And that works by conversion to photoisomers. It changes the configuration of the bilirubin molecule by the effect of UV light on it, which renders it water soluble, which means it can be excreted without conjugation. So that clearly has an effect on bilirubin, which is deposited in the skin. And so we want to make sure that there's plenty of skin exposed to the blue light, because it's a direct effect of the exposed skin and the bilirubin deposited in the exposed skin on the light which you shine on the baby. That is the mainstay, and it's usually all the treatment that we need to use, particularly for preterm babies, but it's a way to avoid the build-up of damaging bilirubin levels, and it's also a way to bring them down. Now, we do sometimes need to act more aggressively with measures to more urgently reduce the bilirubin level if it's already got to potentially damaging levels, and particularly if it's associated with hemolysis, which can lead to very rapidly escalating levels of bilirubin. And that would be quite aggressive phototherapy, so multiple phototherapy, 2 or 3 units, sometimes a blanket under the baby as well, the fibre optic blankets, and exchange transfusion. So exchange transfusion is a process by which we cross-match blood to the baby, and as we take blood out, you replace blood with the same volume that you've taken out, and we tend to do a double volume exchange transfusion. And what that means is that you effectively give a transfusion which is equivalent to double the baby's circulating volume, but as much as you put in, you take out. So what you're effectively trying to do is to partly flush out the bilirubin, but also, in particular, if it's associated with hemolysis, you're removing the sensitized red cells and replacing them with red cells which don't get hemolyzed. So that's the two main mechanisms by which an exchange transfusion is effective. It needs intensive care. It needs good vascular access, ideally venous and arterial access. The babies need to be carefully monitored, and there are the potential risks of complications, which usually centre around it being done too quickly. So you get circulatory instability if you try to do it too quickly. You avoid that by monitoring the baby carefully, and we also make sure that the baby's hemoglobin stays level, make sure we've got the balance right, and that we don't upset the calcium metabolism with the anticoagulants that we use. And phototherapy again will be continuing during that process. If we've got a baby who's got quite aggressive hemolysis, particularly rhesus hemolytic disease, and you're waiting for the blood to come for exchange transfusion, because it has to be cross-matched and can take sometimes 4 to 6 hours to be available if you haven't asked for it in advance, then we can give intravenous immunoglobulin, IVIG, which effectively works. You give industrial amounts of junk immunoglobulin, which just blocks the binding sites on the white cells, which means that they then can't latch on to red cells and destroy them. So that's the main mechanism of the use of IVIG. It's not used a lot, but it is something which can be useful as a temporising measure with severe hemolysis. Next slide, please. So phototherapy, as I said, is the mainstay. So it's mainly blue light phototherapy. Interestingly, if you wanted an optimal wavelength, we might even be using green light phototherapy, but blue light has won the day, and all the phototherapy units are blue light. It's given overhead just by phototherapy lamp, or it can be given by fibre optic blanket. The old-fashioned lamps with strips in them tended to produce quite a bit of heat. The newer lights, which are mainly either fibre optic or LED, don't tend to give too much heat, and they're also much more effective. So I think the technology for the use of phototherapy has improved, certainly during my working lifetime. We often use this as a single phototherapy unit. If we need to intensify the effect, we can use 2 or 3 to make sure we're getting at the baby from all angles, and the maximal effect will be from having as much of the baby's skin as possible exposed. The peak effect for the clearance is in about 24 to 48 hours. As I said, we can intensify the phototherapy for severe jaundice. We do use eye protection for the babies because they've got the lamp focused on them, and it could potentially injure their eyes or be bad for their retina. There's an interesting debate which comes up about trying to support breastfeeding, because we want, particularly from the baby-friendly point of view, we want to make sure that we're doing as little as possible to interrupt that and try to support it as much as possible. And in a baby with moderate jaundice, there is some evidence that once you've been under phototherapy, the photoisomers have been excreted, and it takes about another 3 hours or so to deposit more bilirubin into the skin to be managed again by phototherapy. So there is certainly an argument which would support, in moderate jaundice, interrupting the phototherapy for an hour or so to allow mum to breastfeed, and that would be a positive thing. But in a baby with more severe jaundice and having to work harder with more intensive phototherapy, I think we would have little choice but to interrupt breastfeeding. So it's a matter of judgment and trying to do the proportionate thing without putting the baby at additional risk. Next slide, please. So our thresholds for intervention, this really ultimately means thresholds for initiation of phototherapy, are gestational age specific, as we've said. So it tends to be roughly 10 times the baby's gestational age minus 100. That's the broad sort of kick-off before we started using the NICE charts. So the lower the gestational age, the lower the threshold for initiating phototherapy. The thresholds for commencement of phototherapy and exchange transfusion are for guidance, and they're not absolute. and it does require clinical judgment as to whether the baby is at greater risk. It also requires clinical judgment as to whether you actually need to do an exchange transfusion when you're at that level, or whether you can expect realistically to bring it down with phototherapy. So that's a question of balancing risks and trying to do the right thing at the right time. Next slide, please. This is printed from the NICE guidance. Now, for some reason, my computer's given us rather strange figures on the y-axis, but when you print it out, usually you get whole numbers so that it's easier to read. But essentially, it tells you that this is gestational age specific, so this is 38 weeks and above. So the threshold is around about 350 once you get beyond about 72 hours of age, and the threshold for exchange transfusion is about 100 above that. So that's a broad guidance, but the point that is often of interest is that between the first 24 to 72 hours, you've got an uphill line. So it doesn't mean that a bilirubin level of, let's say, 150 on day one is going to cause kernicterus. It simply means that if you've got a bilirubin level that high that early, it's probably on the way up and it's probably rising rapidly. And so the reason that you've got the upward slope in the first few days of life is because if the bilirubin levels are getting close to those levels, it's likely they're going to be increasing rapidly, and so you need to intervene earlier to stop, to interrupt and prevent that continuing rise. And that really largely comes from babies with hemolysis. So we often, in a preterm baby, you'll often see the babies get a little bit of phototherapy in the first day or so because they've got a bilirubin of maybe 50 or 60 on day 1 or 2, which is just above the phototherapy line. Good practice to start the phototherapy, but you often find it comes down very quickly, and it's just the line's got to be drawn somewhere. But the reason for having the line at a lower level in the first few days is to try to anticipate and interrupt a rapid early rising serum bilirubin level. Next slide, please. So this comes from the original 2010 NICE guidance on the management of neonatal jaundice, and in my view it was one of the most valuable tools in that guidance. I might be being slightly provocative in what I'm going to say, but in practical terms, what this shows you, you've got the baby's age in hours down the left-hand column, and you've got 4 columns there with bilirubin thresholds. So imagine yourself as the community midwife on a Friday evening with this baby who's above 38 weeks gestation and is 24 hours old. The baby appears clinically jaundiced, and NICE guidance tells us correctly that if you appear jaundiced, visual inspection cannot make any accurate estimation of the severity of the jaundice, so you must measure the serum bilirubin level. So you diligently measure your serum bilirubin level, and in your 24-hour baby at 38 weeks gestation, you want to know what you're going to do, because it's Friday night and you've either got to send the baby to hospital or you've got to manage the baby over the coming weekend. So let's say, for the sake of argument, at 24 hours your serum bilirubin came back at 80 micromoles per litre. You'd look at this chart and you would see that at 24 hours, if it's below 100, then all you need to do, you don't need to do anything. You're below the threshold for intervention. You can be reassured. Conversely, if at 24 hours of age your bilirubin was above 100, it wouldn't be above the phototherapy line, but on this threshold you would say, actually it's not at a level that I can be completely reassured, therefore I need to repeat the bilirubin measurement in 6 to 12 hours time to make sure it's not going any higher. And I've found this to be of great value, both for reassuring our practice that you've got a baby, can you safely leave this baby for another 24 hours or over the weekend? Well, it helps you with that. But most importantly, it helps you to recognise the baby who may not be at the point that they need phototherapy, but they're at a point when you may be able to anticipate that they're going to get more jaundiced, and therefore you want to make sure you either repeat the sample, or conversely, if it's even higher, they've reached the threshold for phototherapy. But it's the left-hand column in this chart which I find most interesting, and I have found in my clinical practice and teaching our midwives most useful. So that's in the 2010 guidance, which I think you can still access because it's still valid, although it's been updated a couple of times. But that's it for reference. Next slide, please. Now, this was a piece of work which was done by Vinny Butani in Pittsburgh, and it's old, it's 1999, but what effectively they did, bearing in mind this was in North America, where in North America babies are being discharged from hospital and they generally don't have the safety net of community midwives or neonatal outreach. So when the babies are discharged home, they have not got the same sort of safety net that we would enjoy in the NHS for following the babies more closely after discharge. And so they would recognise, or did recognise at that time, that they had a high rate of readmission of babies from the community with jaundice and potentially damaging jaundice. And the theory that they wanted to test was whether you could anticipate babies who are going to get more severe jaundice by measuring their early serum bilirubin levels. So what this piece of work did, effectively, they measured loads and loads and loads of serum bilirubin levels before discharge, and they developed a mathematical model, which is what you see here. Now, you'll have to forgive the units, but 20 milligrams per deciliter is 342 micromoles per litre. So 10 is about 170. So that gives you the sort of SI unit equivalent. But what it tells you is that by measuring the baby's serum bilirubin according to their age, you could see whether they were at low risk, intermediate risk or high risk for developing more severe jaundice later. And when put to the test, this has proven to be very effective. And so it meant you could identify the babies that you didn't want to send home early because they were likely to get more jaundice, and you don't want them in the community, you want them to be in hospital and perhaps starting phototherapy. So I think this is a seminal piece of work which has really proven useful in clinical practice, and I think is often not remembered as much as it perhaps should be, but that's where it comes from. So it's well over 20 years old now, but it still holds true. Next slide, please. So this is the 2023 update for the NICE 2010 guidance, so the current advice. And so it reiterates the point that visual assessment of jaundice is unreliable. So if the baby looks jaundice, you must measure the serum bilirubin level. And one of the more common remarks I see written in postnatal records, particularly by midwives, with no disrespect to the midwives, is they're right, oh, the baby's got a tinge of jaundice, and I don't know anything about it. Well, if you think the baby's got a tinge of jaundice, it means that you can see that the baby appears to be jaundiced. So you must measure the serum bilirubin level. And this has been a source of probably a great deal of increased work for midwives, because it's not always that easy to measure serum bilirubin level. Sometimes we can use bilirubinometers, but not all places have those available. They're expensive, they need to be maintained, they need to be calibrated. So actually measuring a bilirubin level, I recognise, is not always as straightforward as saying it. But bear in mind, if you've recognised the baby's jaundice, then by our contemporaneous national guidance, you have to measure the bilirubin level, and there isn't a defence against doing that. So a tinge of jaundice written in the notes, you're A, you're not serving the baby well, but B, you're not serving yourself well either. So clinically apparent jaundice, even a tinge, needs a measurement of the bilirubin level. If the babies are over 24 hours of age and more than 35 weeks gestation, then the bilirubinometer is considered to be effective, provided it's giving you a level below 250. If it's indicating a level above 250, you need to repeat it and do a serum bilirubin measurement. That's the way that they work out. So I think there are more bilirubinometers around now, but they're still not cheap, and some are better than others, and they do need to be looked after and overseen by your point of care testing people in the hospital. So it's not a question of just going out and buying one. It has to be part of your practice. I recognise that isn't always straightforward. We've talked about the age-specific bilirubin levels and the risk stratification, and that really is simply the bilirubin threshold charts for phototherapy that I've shown you. So that just means that more immature babies get phototherapy at a lower level and a higher level for term babies. That remains, and you can still download those on Excel sheets. It recognises the importance of identifying other associated clinical risk factors. So those would include, for example, a baby who's got excessive bruising, perhaps from a von tooth delivery. There's a lot more extravasated blood there. That's a bilirubin load, which is going to make the baby jaundice more likely than not. If there's a family history of a baby, a previous baby who's had significant neonatal jaundice, that's relevant and is a significant risk factor. And some ethnic groups as well. So babies with more pigmented skin, it is more difficult to recognise bilirubin, but also some ethnic groups are more likely to have conditions which can predispose to severe jaundice, particularly glucose 6-phosphate dehydrogenase deficiency, G6PD deficiency, which you may see in more in some Asian communities and also Eastern Mediterranean communities as well. So being aware of that, and that can be relevant for family history too. So the current recommendation from NICE is that if you've got jaundice in the first 24 hours, you need to continue 6-hourly bilirubin measurements until the level is either stable or falling and remains below the treatment threshold for phototherapy. So that's what they say. And they say any baby over 24 hours of age who has clinically apparent jaundice, you need to measure the bilirubin within 6 hours of making that observation of jaundice. So that's where they're at. Next slide, please. So I think what we need to think about is the specific clinical presentations. So a baby with early neonatal jaundice, which will by definition be in the first 24 hours of life, clinically evident jaundice, that would always be significant because it's relatively unusual and it's more likely to have an underlying pathological cause. And in particular, those two pathological causes which need to be excluded is hemolysis, and the danger from hemolysis is that it can give rise to very rapidly rising serum bilirubin level, and infection, sepsis. And the reason for recognising that early, of course, is that sepsis can very rapidly progress to become life-threatening, and one of the first signs could be early jaundice. So jaundice in the first 24 hours, consider hemolysis, consider sepsis until proven otherwise. But both of these can give rise to a rapidly rising level, so we need to measure our serum bilirubin and make sure that we're keeping it under review as well. Next step, please. So hemolytic disease of the newborn is much less common than it used to be. Most hemolytic disease is due to rhesus incompatibility, and it used to be mainly anti-D antibodies, and certainly in the time when I was training as a registrar, we used to do loads of exchange transfusions on mums who had rhesus incompatibility due to anti-D antibodies, which shows I'm quite old, I think, because of course now we have the benefit of anti-D prophylaxis for rhesus negative women, which means that the number of ladies who are rhesus negative come up for childbearing age with rhesus antibodies is much lower. So it's dramatically reduced the prevalence of anti-D antibodies and therefore anti-D rhesus hemolytic disease. But what we have seen is, of course, there's a prevalence of the other rhesus antibodies, particularly anti-E and anti-big C or little c antibodies. There is no prophylaxis against those, so they remain a problem. So it's a lady who's rhesus negative who has a partner who's incompatible with those antigens. They can still raise antibodies, and those are the ladies who present the risk of isoimmunization and hemolytic disease of the newborn. Our obstetric colleagues have got very good at managing this, and it's really very unusual now to have a baby born with severe hemolytic disease. We used to get babies who are profoundly anemic, hydropic, but that isn't allowed to happen now because there are antenatal interventions for monitoring the baby, recognising developing fetal anemia and giving intrauterine transfusions, so that the babies actually, when they're born, are born in quite good condition because the antenatal management is worlds better than it was 30 or 40 years ago. But if you've got alloimmunization, what that means is that mum's antibodies cross the placenta and then they attack the baby's antibodies in the circulation in utero. They can cause anemia, but after the baby's born, they can cause hyperbilirubinemia or jaundice. So that's clearly the risk factor for jaundice is the accelerated rate of red cell breakdown. ABO incompatibility is when mother and fetus have an incompatible A or B blood group. That tends to present beyond the first 24 hours of age, but on rare occasions it can cause severe jaundice and early hemolysis, but it tends to be a cause of delayed jaundice, and it's one of the reasons for babies getting readmitted with later jaundice. Next slide, please. So jaundice after 24 hours, much more common. As we said, physiological jaundice reflects immaturity of the ability to conjugate bilirubin, and breast milk jaundice is an exacerbation or potentiation of the enterohepatic circulation of bilirubin, as we've talked about. They're generally benign unless they're complicated by other factors, in particular dehydration. And I think that Sharon mentioned in her preamble, one of the concerns that we might have is babies who get severely dehydrated because of difficulties, particularly with breastfeeding, and that can increase the risk for jaundice. To some extent it can, so that's another risk factor, the dehydration, but it's a feature of a baby who's getting out of control, and the jaundice is a part of this baby in a downward spiral. Not forgetting that babies can still present with sepsis later, and they can present with hemolysis later, in particular G6PD deficiency, which tends to present around about day 4, day 5 with increasing jaundice. So it's one not to forget. And remember that some ethnic groups or family histories would alert you to that possibility earlier. Next slide, please. So we should talk about prolonged jaundice briefly. I'm not going to say too much about it, but essentially what we've described is that most babies with jaundice have unconjugated jaundice due to limitations of the baby's capacity to conjugate bilirubin and some effect on enterohepatic circulation. But because bilirubin induces its own metabolism, it tends to be a self-limiting process. And so other than breast milk jaundice, which can linger mainly because of the continuing enterohepatic circulation, it tends to be a self-limiting thing. So babies who remain jaundiced beyond 14 days, that's our definition of prolonged jaundice, need further investigation. So the first thing we'd do would be a split bilirubin, measure the conjugated and unconjugated bilirubin. So with breast milk jaundice, it will be almost all unconjugated, and that's relatively benign, or it is benign, as long as it's not getting any worse and the baby's feeding well, gaining weight well. So it's a diagnosis of exclusion. But what we want to be careful about is that we're not overlooking other causes of jaundice which have potentially serious outcomes. And the one which will be in all of the undergraduate textbooks will be biliary atresia. And that's when you've got an obstruction to bile flow out of the liver. And so if it's not recognised in time, then you get damage to the liver. The way that we'd recognise biliary atresia, it will give rise to a conjugated jaundice, because it's like backing up from the liver. It's not the liver being overwhelmed, but it's cholestasis and backing up of the conjugated jaundice. So you'd have a high conjugated fraction of your jaundice. And one of the hallmarks of biliary atresia is that you get pale stools, because if you haven't got the bile pigments coming into the stools, the stools look pale. So it's important to recognise that early, because the surgery to deal with biliary atresia, which is a portoenterostomy, it's a Kasai operation, which basically anastomoses the bowel with the portohepatis, and so that the bile can drain into the bowel. That's most effective if it's done within the first few weeks of life, and if it's delayed beyond about 7 or 8 weeks, there's a danger that you can have established liver cirrhosis by that point, in which case you've got a bad outcome and you're more likely to need an early liver transplant. So that's a conversation for another day, but the important point is that if you've got obstructive jaundice and biliary atresia, it's important to recognise it early. This is how we recognise it. You could have neonatal hepatitis. There's different things which can cause that, including metabolic problems, including endocrine problems. They come up in investigation, and there can be hemolysis going on. G6PD is usually presented earlier, but there can be other red cell defects like pyruvate kinase deficiency, which is means the red cells have a shorter lifetime. And then there's rare conditions. We got one family in Manchester with Crigler-Najjar syndrome, which is essentially it's a congenital absence of or significantly reduced function of glucuronide transferase activity. So these people have conjugated jaundice forever, and they need to have phototherapy for the most severe cases for the rest of their lives, or some of them are managed with when they've got a little bit of residual activity with phenobarbital or other enzyme inducers which can increase the level to keep their bilirubin levels under control. The interesting part for these ladies can be when they get pregnant, because bilirubin crosses the placenta. So if mum has got a serum bilirubin of 300, so does the fetus. And so there are concerns to make sure when these pregnancies are managed that we control mum's bilirubin level as well. But we've only got one family, and the chances of coming across another one are quite small, but they do appear from time to time. Next page, please. So Neonatal hepatitis, well, there may be other signs of liver disease, like an enlarged liver or part of the condition which is giving rise to liver disease. We need to consider congenital infection, particularly cytomegalovirus. We need to consider metabolic conditions, particularly galactosemia and tyrosinemia. Galactosemia is treatable by avoiding lactose in the milk, whereas tyrosinemia is something which needs to be recognised early because it can benefit from an early liver transplant before you get progression of the disease as well. But other metabolic problems can also give rise to these issues. Then endocrine problems, so hyperpituitarism and hypothyroidism are recognised causes of neonatal hepatitis, and we've already mentioned biliary obstruction and biliary atresia. So that's why we have a rapid access prolonged jaundice clinic, send the babies along to be checked. Majority will just have breast milk jaundice, but some of them will have underlying conditions we need to pick up early to deal with. Next slide, please. So I just wanted to use one particular case history. This was a medical legal case, but I think it illustrates the difficulty quite well of recognising early jaundice. So this was a little fellow, he was an African Caribbean baby, but the fact he was African Caribbean didn't have too much to do with it. He was born at 37 weeks gestation and he weighed 2.82 kilos, which means he was not growth restricted. He was born in good condition after an uncomplicated pregnancy and didn't have any problems. He was on the postnatal ward of his mum, normal neonatal progress. So it was a Friday and the baby was 50 hours of age, and the midwife noticed that he was jaundiced, and so she checked a serum bilirubin level and it was 224 micromoles per litre at 50 hours of age. So she asked the paediatric SHO to give some advice. So the paediatric SHO came along and looked at the bilirubin level, looked at the phototherapy threshold chart and said, that's okay, you don't need to do any treatment, so you can go home. So baby was discharged home breastfeeding. Excuse me, I'm going to cough. Excuse me. So he was meant to be seen over the weekend. He was seen once on the Saturday by the community midwife. There hadn't been any communication of the pre-discharge bilirubin level, but independent of that, the midwife who saw him on the Saturday did notice that he was jaundiced, but didn't raise a concern and didn't take any action. And he was supposed to be seen again, but the midwife visits got delayed until day 6. When the midwife went to see him, and he was deeply jaundiced, had been for days, poor feeding, drowsy. So she, at that stage, rightly sent him back into hospital. And when he was readmitted, he had a serum bilirubin of 606 micromoles per litre. He was showing signs of encephalopathy. It proved actually he did have G6PD deficiency. That was the cause for his jaundice. But sadly, in the long term, he got full-blown connectrus. So he's got the MRI changes of basal ganglia injury, and he's got an athetoid cerebral palsy with a vertical gaze paralysis, and he's also deaf, sensorineural deafness. So this poor young man's life is ruined, and the question is really, could it have been avoided, and should it have been avoided? And in fact, the case settled out of court in favour of the claimant for a very high proportion, and I'll tell you why. Next slide, please. So this is going back to the Vinny Butani graph I showed you of our specific bilirubin levels, and I just do this for illustration, but if you convert 224 to micromoles per litre from the milligrams per decilitre, that's where it is. So you just got to do a conversion, so it's 13.1 milligrams per decilitre, but you can see at 50 hours of age that would put him in the high intermediate risk zone. So you could have anticipated, if you were using that chart, which NICE doesn't, but if you were using that chart, there was good evidence to anticipate that a serum bilirubin of 224 at 50 hours of age was not reassuring, and that's been published for a long time now. It's well known. Next slide, please. And the next one is this 2010 NICE guidance, which at the time was current, and that clearly shows you in the left-hand column, if you look at 48 hours of age, over 150, repeating 6 to 12 hours, over 200, consider phototherapy, 54 hours. Again, the very minimum they would have done would have been to have kept him in hospital that Friday evening and repeated the bilirubin in 6 to 12 hours, or they'd have started phototherapy. either of those actions would have recognised a rising serum bilirubin level and would have avoided the catastrophically high serum bilirubin that this baby got. And that simple measure, which is just staying in hospital and giving phototherapy, would have avoided the high bilirubin level. It would have avoided his kernicterus. It shouldn't have happened if this was what had happened. And that's the reason why this case was settled for the baby. It's not a good outcome because no amount of compensation can ever make up for the disability this little fellow has. Equally, the staff involved, none of them went to work that day intending to fail to look after the baby. It was a genuine mistake, and it's a mistake which I hope we can learn from, and it's why I tend to labour the point of the early bilirubin levels. It's the first time you've done a bilirubin level, you've got no previous one to compare it with. What do you do? And you may well be that community midwife on a Friday evening. In this case, they were actually in hospital, so it would have been even easier. But recognising the relevance of an early bilirubin level is important. Next slide, please. So coming to 2023, the threshold table in the 2023 NICE guidance is this. And as you can see, what they've done is that left-hand column has gone. So in fact, the two left-hand columns have gone. So I think you need to look back to a 2010 guidance to have the benefit of those two columns, which I find are hugely helpful because this one doesn't really do much more than just reiterate the phototherapy threshold, which is perhaps already shown on the phototherapy threshold graphs. What some people do is say if you're 5 boxes below the phototherapy line at any given point, you can probably be reassured. I don't think it's quite as accurate, but I think it is a genuine issue, and I think that we need to be more alert to the interpretation of this first isolated serum bilirubin level in the first few days of life, because it can give us so much more information, and it can allow us to anticipate babies who are going to get into difficulties later. So I think that my personal view is that the NICE guidance works well as a package, but there are some elements of the 2010 guidance which is very much more comprehensive, which I don't think should be not read because there's a 2023 update. The update goes with the 2010 guidance, so they should be read together in my view. Next slide, please. So again, that's our NICE threshold chart, and that's the reason why the SHO came along at 50 hours of age and said bilirubin of 224 was below the phototherapy threshold. He's right, it was, but it wasn't far enough below to be fully reassuring. So it just means we've got to be alert to this, and you've got to think about it. But that's one particular tragic story which I can relate to you when this really illustrates that point. Next slide, please. So what we commonly have to consider is a practical consideration, what we're going to do with this baby. So it's early discharge from hospital, or they're already in the community. So to recap, can we be reassured by the current bilirubin level? Well, you can if you go about it in the way that I've just described. Equally, you can be pre-alerted to the risk of the baby needing to be sent in. You can get a heads up of the baby that you can't leave in the community over the weekend, or you don't want to send home, and you can act appropriately. So it involves the need for the repeat level. Don't rely on the phototherapy thresholds. They are just that, but by the time you get to a phototherapy threshold, you're into the level of jaundice that needs treating anyway. We're trying to anticipate this, and as I said, the revised threshold in the 2023 guidance I think is less robust than the 2010 threshold. I think it's not maybe, it undoubtedly is useful, and I used to stick it on the wall in our postnatal ward. Next slide, please. So there is the spectre of so-called low bilirubin kernicterus, and the reason I mention this is that although it's rare, it does happen, and I think that it's recognised, but it's not recognised well enough. So what we're describing in this instance is a baby who develops bilirubin-induced brain injury at a level of bilirubin when we weren't expect it to happen. So this would be usually a preterm baby, and the babies who get into difficulties tend to be those who've got low albumin levels and they've got coexisting infection or inflammation, and sometimes there may also be concomitant brain injury like developing PVL or germinal matrix hemorrhage, which increases the risk. It's likely that what's happening is that you've got an increased flux of unbound bilirubin across the blood-brain barrier, and so although it's less of a reflection of the total bilirubin level, but it's the fact that more unbound bilirubin is able to get across the blood-brain barrier and cause damage at levels, absolute bilirubin levels, that we weren't anticipating it. So in babies who are preterm, who've got a rising serum bilirubin, particularly in the presence of a raised CRP and a low albumin level, then we should be alert to that risk. And in my view, we should be starting phototherapy earlier, even before they get to the phototherapy level. So it's true that prophylactic phototherapy doesn't work, but that is starting phototherapy before your jaundice. But when you've got a raised and rising serum bilirubin level, then starting phototherapy earlier will bring that down and avoid it going up. And you can anticipate this in basically a sick preterm baby. And I think most people would start phototherapy more aggressively in a sick preterm baby, but I think we need to just consider the nuts and bolts of that and why we're doing it. It is a rare entity, but I can tell you from our experience, about 10 years ago, we had a baby in St Mary's who got connectrous at 36 weeks gestation, and the bilirubin was never above about 220, I don't think. And that baby had coexisting infection with a very high CRP and a low albumin, and they got full-blown connectrous. So you can definitely get your fingers burnt badly if you're not very careful. And so I speak from my own experience. It's something which needs to be highlighted, and we do need to be more alert to the effects of the potential for low bilirubin connectrous in this instance. Next slide, please. So this was about connectrous in the UK, and so we can learn from our mistakes. Well, this was a review of cases on the database of what there's NHS Litigation Authority, now NHS Resolution. So they're the NHS body who underwrite the NHS. So they basically investigate and pay out on claims for clinical negligence in the UK. So these are cases of connectrous occurring in the UK, bilirubin encephalopathy in the UK, in whom it's been found to be avoidable, and therefore there has been compensation paid. So as I said, I'm not so interested in the compensation as the ruined lives, but it's a reflection of that. So among babies in this situation who are born at term or near term, there's commonly a very significant delay between recognising that they appeared jaundice and actually measuring a serum bilirubin level, and the range was between 26 to 102 hours. So that's a very simple thing, isn't it? In the NICE guidance, if the baby looks jaundiced, you should measure the bilirubin within 6 hours. If you don't, you're not complying with the NICE guidance, and one of the consequences of that can be this sort of thing happening. So an important feature in these cases was that there was generally a very significant delay between recognising clinical jaundice and actually measuring the serum bilirubin level, and that had consequences. And in a number of the cases, there was an underlying diagnosis, and G6PD deficiency featured prominently, as did ABO incompatibility and a couple of babies with rhesus hemolytic disease. There were a couple of preterm babies in here as well who were still in hospital, but the majority of the babies who were developing connectrous were term babies in whom there were underlying conditions. So very much like the little boy I told you about, a G6PD deficiency, but the problem was a delay in measuring the serum bilirubin level, which you can see here. So I think this was actually, yeah, he will have been, the case I've described to you will have been one of these cases. He's in among that data. Next slide, please. So I think what comes out from that is that we need to recognise the importance of an early serum bilirubin level in any infant with clinically apparent jaundice. If the baby looks jaundiced, please don't delay measuring the serum bilirubin level, whilst not underestimating the fact that that can sometimes pose practical difficulties. It's important, and we need to find ways around that. That's for our local practices. there is a potential through this to anticipate the babies who get severe jaundice from that early serum bilirubin measurement, but you need to be able to have a measure which is the threshold table, I think, and it's in the 2010 NICE guidance, and it's hugely valuable in my view. We can recognise babies who are increased risk, so we've got a lower threshold for intervention and maybe checking a bilirubin level. So a family history, particularly of early neonatal jaundice, but there can be a family history of other conditions, including G6PD. Ethnicity, well, some Asian, Eastern European families are more likely to have G6PD deficiency. Babies of darker skin, it can be more difficult to recognise jaundice. It's a factor. Babies with extensive bruising, particularly after von tooth, for example. There's a lot of exudated blood, they're at greater risk of jaundice. Prematurity. And then if there's coexisting infection and hyperalbuminemia, particularly in the preterm babies, then we can recognise that as a risk, and it means a lower threshold for earlier initiation and maintenance of phototherapy. Next slide, please. Okay, so I think that brings us to the wrap up. So it might be time for me to let Sharon get a word in edgeways, and also for me to open the floor for questions.
Yeah, thank you for that. That was absolutely fascinating, and there's so many points I think for people to take away in terms of the learning and the guidance that you've provided. And I think it just shows how important it is, particularly for community midwives, to be really aware of all the early signs of jaundice and what they need to do, because it's so prevalent in terms of discharging mothers as early as possible from hospital. There has been a few questions, so if you don't mind me firing those at you. Yeah. Talking about community midwives and obviously the guidance levels, and the fact that it seems to have been a bit more muddied recently with the 2023 update. One of the questions that we've had is, why has the 2010 threshold table been removed from the 2023 guidance? Do you have any idea as to why that might have been?
I don't know. I wasn't party to it. It's a recent thing. I think that the 2023 guidance, I'm not sure that it was actually originally revised in 2016, and the 2016 revision didn't replace the 2010. So I'm not sure whether the 2023 is meant to be seen as a sort of a summary, or whether it does supersede it. But the only, if you were being pragmatic, you might take a view that the approach that I've outlined to you might lead to you doing more serum bilirubin levels, and somebody might have sat down and said, well, we do that many more serum bilirubin levels, how many babies are going to pick up from doing it? But my reading of the 2023 threshold table is that really it mirrors the phototherapy graph rather than going beyond that. So I think, in my mind, it would be the lesser of the two evils to do a few more bilirubin levels compared to risking overlooking a couple of babies. So I wasn't party to the discussions which led to the publication of the 2023 update. They will speak for themselves, and they may have reasons for it, but I think in my own clinical practice, I would challenge that. And I think the other thing about NICE guidance is that it is guidance. If your practice is being held to account, then the NICE guidance is a standard, like a minimum standard to which you should be practicing. And if you don't comply with NICE guidance, then you're going to be criticised. There's no criticism for exceeding what's recommended in the NICE guidance. And I think that the 2010 guidance was the most comprehensive guidance on neonatal jaundice in the world, and it's commonly cited across the world. They cite it in Australia frequently. So I would stick to my guns and be aware that there is a useful instrument in the 2010 guidance which can be very helpful in that situation. I think I've probably avoided that question, haven't I, really? But essentially, it's not immediately clear to me, but I think the 2010 guidance still stands, and I don't think anyone's going to criticise you for exceeding the 2023 guidance, but they would criticise you for not meeting it.
Thank you. Another really interesting question that's popped up is how, in your opinion, how are hospital infant feeding policies and practices, so those promoting exclusive breastfeeding and withholding formula supplementation, contributing to the rise in hospital readmissions in the early days of life for neonatal jaundice?
I think the more commonly would see readmission due to difficulties with feeding. Excuse me. From a forensic perspective, babies who are discharged home from hospital before they have initiated effective breastfeeding are the problem. So it's early discharge, often in a first-time mum who hasn't successfully initiated breastfeeding, and from a neonatal perspective, and generally confirmed by expert midwifery advice as well, there hasn't been an adequate assessment of the efficacy of breastfeeding before the baby goes home, and that's midwifery expertise. So you've got a baby who goes home and they haven't established feeding properly. The risk of two things, that the problems that we tend to get is weight loss, but the potentially damaging problem that we get from these babies is actually hypoglycemia, and it's a relatively common situation. And again, there is a parallel NHS resolution review of babies who were litigated with hypoglycemia, and the most common situation among those babies was a failure to recognise a change in feeding behaviour in a baby who was failing to establish breastfeeding. That was the commonest circumstance under which NHS resolution paid out for damaging hypoglycemia that could have been avoided. In terms of readmission for jaundice, I'm not aware that it's a huge impact on that. It's just that if babies do get jaundice and they're significantly dehydrated, they're likely to get sicker. So most of the babies who seem to be getting readmitted for feeding difficulties, in my experience, it's often those who have been discharged quite early when they haven't established effective breastfeeding yet. And how that should best be managed will, of course, fall to expert midwifery practice as to whether there's direct support for breastfeeding, whether there's supplementation of feeds, and all the things which you can talk about better than I can. But I would see that the key from a neonatal perspective is the babies who get sent home early before they've established effective breastfeeding and continue to struggle after discharge, and they are at risk of hypoglycemia. And if they do get severely jaundiced, it's likely to make them sicker too.
I think that topic of effective feeding has come up quite a few times in various webinars that we've done, and it seems to be a really key area of research, really, and where more work needs to go into. Another question that's come up is, you've touched on ethnicity. What is being done by NICE and other medical education institutes to educate UK clinicians, so doctors and midwives, about jaundice in babies with darker skin tones?
I think it's highlighted in the NICE guidance as a potential risk factor, but that simply is that there can be, G6PD is one particular feature which is more common in some ethnicities. But in terms of recognising jaundice in babies with darker skin, it has been indicated it's more difficult. In terms of could we do more, I think the person asking the question is absolutely right. We could do more to increase awareness of this. As an anecdote, the baby I told you about with the G6PD deficiency, he was an African Caribbean baby, and the midwife looking after him was also African Caribbean, so she'd recognised that he was jaundiced, which is why they did the jaundice level before discharge from hospital. And the problem with him was in failing to appreciate the significance of the absolute jaundice level. But in terms of being more alert to the presence of jaundice, in particular looking at pigmentation of the sclera in babies with darker skin, I think there is room for greater emphasis to be given to that. And I take that point.
Again, it's another common theme that's come up, and I'm thinking about some of the cases that we've been successful on, and we've got published on our website in various PASL articles. A lot seems to be mums not being listened to, and if you don't know how to recognise those signs in a skin tone that you're not familiar with, mum is the person that knows their baby best. If they're highlighting to you that something appears to be wrong in colour, mum has to be listened to.
Yeah, listen to mum, I agree.
moving on to phototherapy, we've had quite a few questions about phototherapy for you. One is, can the phototherapy unit go over the baby while they're breastfeeding? And is there a specific distance that the baby needs to be for phototherapy to be more effective?
It depends on there's probably 4 questions there, or 3. So in terms of a distance between the machine and the baby, it will vary between the machines that you're using. We tended not to have them too close when they were the old fluorescent strips because they got too hot, whereas the fibre optic and the LED ones tend to be more effective and don't get so hot, so they can be closer. I think the main thing is that the baby is within the manufacturer's recommendation, which is usually about 1 metre or so, something like that, but it'll tell you in the handbook. And also that the baby's skin is exposed, so making sure that there's exposed skin getting the blue light on them and it's overhead. In terms of breastfeeding, I think it's probably quite difficult to actually do overhead phototherapy during breastfeeding. I've certainly seen babies using, or midwives and mums using, a billy blanket, which is a fibre optic blue blanket wrapped around the baby to breastfeed. You can do that, but I think it's in terms of evidence, what we can say is that the way phototherapy works is that it converts the bilirubin in the subcutaneous tissues into a photoisomer, which is water soluble and is excreted without needing to be conjugated. And it takes about 3 hours for the normal bilirubin to reaccumulate in the skin once it's been cleared in that way. And so there is some evidence to support it interrupting phototherapy for breastfeeding when you haven't got very severe jaundice, because in fact it'll probably be just as effective. The only proviso on that, and a baby who's got more severe jaundice, when you're really having to work hard to get the level down, then I think that the balance of risks then would be to unfortunately interrupt breastfeeding. But a baby who's got a bit of physiological jaundice and they're just above the phototherapy line, but it's coming under control, then I think it's clinical judgment. But I would be inclined to take the baby out, breastfeed them and put them back under again, unless you're using a billy blanket, which can of course facilitate continued phototherapy while you're breastfeeding. I wouldn't give overhead phototherapy while you're breastfeeding, because then you're irradiating mum as well, which means that that's inappropriate. So you wouldn't put mum under the phototherapy light. I think one of the questions in advance of this chat was we give eye covering to the babies, and should we give eye covering to, or should we have eye protection from staff working in phototherapy? And I knew that question was coming, so I had a chance to think about it and read about it. I'm not aware of anything published anywhere of an increased risk to neonatal nurses from exposure to phototherapy. And I think in a pragmatic sense, if the baby's under the phototherapy, it's shining right at them, and the danger is the baby can look straight up into the light as well. Whereas if you're looking after the baby, it's not shining right at you and you're not looking right into the light. So it doesn't appear to be a problem which we've got evidence of an issue for it. But I wouldn't aim a phototherapy unit at mum while she's breastfeeding.
Thank you for that. And you talked a lot about the breastfeeding in terms of phototherapy because of the question that we've just had. Another question follows from that, which is, where does formula supplementation sit with phototherapy?
I think it's completely separate issue. So formula supplementation is something which the midwife looking after the baby will decide it's clinically indicated and mum will accept it. My understanding from a neonatal perspective is the reason we'd supplement with formula is because there's difficulty with supply of breast milk and mum finds formula milk as an acceptable alternative. And it's also when babies are at risk of hypoglycemia or have had low blood glucose levels, then we supplement to avoid hypoglycemia. That wouldn't have any impact, I don't think, on phototherapy. I think it's a question of management of infant feeding then. So the only immediate impact or direct impact I'd see on feeding from phototherapy would be whether you can interrupt for breastfeeding. I suppose the other thing is, if you've got a nasogastric tube in, you could always put your top-up feed down the nasogastric tube while the baby's under phototherapy if you wanted to. because that's a expedient thing to do, but it probably wouldn't be the reason for doing the top-up feeding. The top-up feeding would be for those other reasons, not because of the phototherapy.
Thank you. I think we've got 2 more questions that we can squeeze in. One is, would better practice be to have every baby have a TBR check before discharge?
Well, that's a screening issue, and we've got the body, the NHS National Screening Committee, who do oversight just that sort of thing, and it's a difficult issue, but in fact probably wouldn't meet the threshold for an effective screening intervention, because they have to consider the cost of doing it, the acceptability of doing it, and the benefit that you get from doing it. And as it stands at the moment, the best screen we've got is our eyes, and if we can see the baby looks jaundiced, then we would do a serum bilirubin measurement, and that should be adequate, and there will be few cases when that won't be adequate. That if you can see the baby's jaundice, by NICE guidance, you've got to do a bilirubin level within 6 hours. So that's pretty close to screening anyway. In terms of doing a bilirubin level on every baby, I don't think there's evidence to support that. I think you get an awful lot of bilirubin levels with no intervention needed. I'm not sure it would be acceptable to parents, but I don't think it would be cost effective either, when we have already a cost effective way of recognising babies with jaundice, which is if they look jaundice and then measure the bilirubin level. So I don't think it would be a case for screening. That would be my view.
Thank you. I'm not sure whether you would know this, it might be more into the midwifery side of things, but can you indicate when bilirubinometers became available to community midwives?
They've been available for 10 to 15 years. In terms of you could buy one and use it. In terms of their accessibility, which includes the cost and the infrastructure to maintain them, I would have thought it's probably been about the past sort of 7 or 8 years. I think in Salford and Manchester they've had them about 10 years to my knowledge, but the problem is that they're still quite expensive, and it's not something that every midwife can have in her bag. So if one midwife's got it with her and somebody else needs it, they have to go and get it. So it's not an ideal issue yet. There is one particular make of bilirubinometer available now, which doesn't need to be frequently recalibrated, and that's hugely useful, because the ones that do need to be recalibrated, you need a bit of help from your point of care testing team in the hospital as well. So I think the thing which limits their availability, not inappropriately, is the cost, and they're an expensive article to buy, and they're too expensive to have one each. So at the moment, we're not at the point when they're likely to be immediately to hand for every single community midwife, but that's a matter for local practice. And for example, in Salford, there's a district called Urmston, which is actually closer to Warrington than it is to Salford, and so the midwife going out there might well want to take a bilirubinometer with her, because it's going to be a greater benefit. But that's a local issue. So I think they've been available 10 or 15 years. I'd say 7 or 8 years widely available, but the limiting factor is cost. They're not cheap, and there's lots of competing issues for funding at the moment.
Thank you. I think that was a really helpful answer. We've had another couple of questions come in on the back of some of the answers that you've given there. Just going back to the screening question, you obviously expressed that your view was that perhaps maybe screening, having every baby have a check done, wasn't the right thing to do, because eyes are the best tool that we've got. Somebody's asked, what about babies with brown and black skin and screening? Should they have screening done?
I think you could think about that. It comes down to whether that would be more effective than actually crudely eyeballing the baby. I don't think, I'm not aware that the work has been done to inform that, and it may be that that's a piece of research which could usefully be done. And what it would look like, I guess, would be a little bit like on a smaller scale, the work that was done in Pittsburgh when they were looking at the the bilirubin levels and getting a threshold for them. But a bilirubinometer works independently of skin colour. So what this is depending on is you actually recognising with your eyes as effectively a baby who's got darker skin and is becoming jaundiced. So I could recognise, I can understand in a conceptual way that there could be a reasonable argument that you'd have a lower threshold for checking a bilirubin level in a baby who's got darker skin because you're not sure. In terms of whether they should be done routinely, I'm not aware there's evidence to support that yet, but it could be something which would bear further research, but it would be a research project on the current basis of what we know.
I agree. I think there's a lot more research that needs to go into that area, isn't there? Our final question, it goes back to the guidelines. The 2006 guidelines required significant jaundice before levels needed to be tested after 24 hours old. I see in August 2009 draft guidelines culminating in the 2010 guidelines. This had changed. When in practice did this difference start to be adopted?
Well, the 2010 guidance came in 2010. Before that, there was quite a lot of variability in practice across the UK, and a lot of people were using bilirubin threshold graphs which are based on quite historical data, and most of that data was derived from the days when there was extensive rhesus hemolytic disease, so the threshold for phototherapy was a bit lower and it wasn't quite so specifically gestation dependent. So the thresholds would be quite different between, and the practice is quite disparate between different units, even across the UK, even across parts of the UK. And one of the things that NICE tried to do was to actually get consistency by having an evidence-based consensus. That's what it did. So I think if you look before 2010, you will find quite a bit of variation in practice.
Thank you. I think that's all of the questions. Oh, I think one more has come in, which I think we can just about squeeze in. There's at least one RCT that shows that giving formula supplements to at-risk exclusively breastfed babies reduces the likelihood of them needing phototherapy. Should parents be made aware of this as an option?
I would leave that to the midwives counselling the baby. The way I'd approach that question, if it was asked of me, would be that there are a lot of benefits to breastfeeding, and the reason that we promote breastfeeding is for the short and the longer term benefits from breastfeeding. It remains, as we've discussed, breastfeeding potentiates the enterohepatic circulation of bilirubin, and so the babies are more likely to get a degree of jaundice. But that's probably not that, it's not in itself likely to be harmful. So if mum is choosing to breastfeed to benefit her baby, then I would place a greater emphasis on supporting breastfeeding and making sure that she's breastfeeding effectively and she's being supported, then certainly before discharge from hospital. I can see if you're doing formula top-ups, you're going to avoid dehydration. You're probably also going to change the bowel flora, which makes the enterohepatic circulation less. But there's actually, it becomes very complex if you start talking about bowel flora, our probiotics, and what is the most favourable bowel flora to have. And there's actually quite a bit of evidence that babies who have exclusive breastfeeding have got a more favourable microbiome in their bowel than those who are formula fed. So I don't think it would be quite that straightforward. So if mum asks, if I give formula feeds, is it going to reduce the risk of phototherapy? It might do, but is that something that you'd want to recommend? I'm not sure that I would, because the breastfeeding per se is beneficial, and we're trying to support that as much as possible, not just for the short-term benefits, but the intermediate and long-term benefits as well. So I would personally put a bit less weight on that, but if I was asked the question, you just have to answer it, I think, in the way that I did.
Thank you. That was very good. I think that's all we've got time for today. So thank you very much for everybody for joining us for such a fantastic topic and really great engagement with the Q&A as well. If you do have any further questions, please do get in touch. Finally, thank you to Simon. That was an amazing presentation with really informative answers. So thank you very much for everything that you've done today, and goodbye everyone.
Okay, thanks very much.